Okay, so let's get started for session 5. So my name is Kenji from the King's College London. I'm session lead. And it's fun time. So we discussed about individual, clinical, biological, and social, environmental, and national policy to global health. And you guys are very smart to identify key issues and challenges easily. But this session will be slightly different. And the big question, how to move the mountain. Because of health people, we tend to talk to ourselves, but we have to go beyond. So the purpose of the session are the following. One is explore system-wide barriers and opportunities for translating knowledge on health longevity into policy and practice. And secondly, consider social and economic opportunities. And thirdly, examine strategies to engage political leadership and also business case, and highlight innovative partnership, collaboration, and mechanism. And plus, I think yesterday Peter Beard mentioned we need to engage people, not just the institution or civil society, but engage elderly people for the practice and the research as well. So I will pass on to Janet to moderate this session. Thank you.
Thank you. So we do have a wonderful group of panelists today. We have Tina Woods, who is the CEO and founder of Longevity International, which is a social enterprise bringing together startups, industry, and academic, and also government. She is also the CEO of and founder of Collider Health, which is a health innovation catalyst working with organizations in both private and public sectors. Tina writes regularly for Forbes and other media channels and is currently writing a book, Live Longer, Better with Artificial Intelligence. So then we have, we have Robert Greenwood, that is the Vice President of Public Affairs at the National PACE Association, and for those of you that you don't know what PACE is a program of all-inclusive care for the elderly, and they have come up with a model of care, and they get funded from the Medicaid and other institutions. So Robert has been working for more than almost 20 years with that institution, and he is in charge of all the PACE communication efforts, including member communications, media outreach, and the use of new media. He has a Bachelor of Science in Journalism from the University of Kansas and a Master in Public Administration from George Mason University. So welcome. Then we have Castleman Nishikawa, who is the Director of the Healthcare Industries Division at the Ministry of Economy, Trade and Industry in Japan. He's a member of the Global Future Council for Human Enhancement and Longevity of the World Economic Forum. He has also worked in the Defense Ministry and Cabinet Office, and he holds a law degree from the University of Tokyo, a Master of Laws from Northwestern University, and a Master of Law in International Studies from Georgetown University. He's also currently an attorney at law in New York State, USA. Then we have Srina Reddy, that probably most of you know, is President of the Public Health Foundation of India and formerly headed the Department of Cardiology at All India Institute of Medical Sciences. Professor Reddy is the first Indian to be elected as foreign associate member of the National Academy of Medicine of the National Academy of Sciences. He has published more than 500 articles. His several honors include WHO Director General's Award and Luther Terry Medal of American Cancer Society for outstanding contribution to global tobacco control, and the Queen Elizabeth Medal for Health Promotion. He was conferred Padma Bhushan by the President of India in 2005, and he has received honorary doctorates from the universities of London, Glasgow, Aberdeen, Lausanne, and 2 Indian universities. So with this panel, I'm sure we're going to have a wonderful session. Let me then begin by asking a very general question. And the question is the following. I want you to explain or talk about one experience where you have been or you have seen a successful transition from knowledge to action, which is always something that we talked a lot, but it's very hard to find evidence on what really, how this process happens and successful experiences. So, Tina?
Good morning, everyone. In response to that question, I thought what I would do is paint a picture of the experience that I've had over the past 10 months setting up and running the All-Party Parliamentary Group for Longevity. So this is against a background where, my background is having worked for many, many years in the pharma industry, and about sort of 7 years ago, I started getting very interested in the impact of the sort of aging demographic and technology as sort of the key disruptive forces that we're seeing today. And I build ecosystems and do a lot of work with the public and commercial sectors to drive change, knowing that to really drive change, you need the influence, you need the money, you need the ideas, and you need the people to drive the change. And with that, I set up Longevity International about a year ago, actually, to the day, really to look at how we could accelerate progress in this whole environment that we're calling, or this whole area that we're calling healthy longevity. And this was after a period of working for a year with the Healthy Aging Industrial Strategy Challenge Fund. Many of you may know, if you're from the UK, that 2017, the UK, they published the industrial strategy and the grand challenges, and there are 4 grand challenges, AI and data being one, energy, mobility, and then the Aging Society grand challenge. So I spent a year working with Innovate UK, UKRI, sort of generating interest amongst particularly the business community to get involved in the call for the bid. And so there's 300 million for the Aging Society Grand Challenge, 100 million was put aside for the Healthy Aging Industrial Strategy Challenge Fund. And the idea around that was to form, collaborative ventures to then put a call in for the bid, which actually happened earlier this year. So it took a little bit of time. And actually what I realized, that there's all this money, and of course, the government money is a drop in the bucket compared to the money that's sitting in the city and pension funds and what have you, which really needs to find a home for very smart investment in this space. And one of the things that occurred to me is the pace of change, and of course I have to agree with David Canning's points yesterday about institutions being the biggest barrier to change in many respects. And I have huge trust in the general public, actually, and I think, we all know that disruption always comes from outside, and I think a big part of this is really trusting the general public and the citizen to really catalyze a lot of the changes that we need to see moving forward. And one goal that the government, and this is the UK government, alongside the Industrial Strategy Challenge, they had a goal which was to deliver on 5 extra years of healthy life expectancy while minimizing health inequality. So that was stated 2 years ago. And what I could see is that there really wasn't an action plan or a strategy around that. So I was seeing, all this sort of money being put up, and of course there's huge amounts of money sitting in the city, as I mentioned earlier, and really it needs to have a much more sort of strategic focus. So with that was the rationale for setting up the social enterprise. And then, of course, set about working with my network to find the parliamentarians to set up this all-party parliamentary group. And very, very quickly, we managed to get the interest of a very influential group of parliamentarians. So Damien Green, who is the former Deputy Prime Minister under Theresa May's government, Lord David Willits, Camilla Cavendish, James O'Shaughnessy, Bob Kerslake, so many sort of very influential parliamentarians, Sally Greengross. We all formed this group, and that was actually less than a year ago. March was the first time that we had our first inaugural meeting. We had our official launch in April, and then actually it was in May, I should say, and at a galloping pace, we managed to pull together over 100 experts in all sorts of different areas. And one thing that we realized is that to really sort of tackle this mission that was stated by government, we really had to take a whole society cross-sector view on this. And I know Damon Green, who's the chair of the APBG, and Lord Filkin, who came in slightly later, who is our Strategic Advisory Board chair. He's the he had set up the Centre for Aging Better and has been a huge driving force in everything that we've done since then. But I know Damon Green, he sort of said, listen, we want the idea bombs. What are going to be the really, really radical solutions that we can take and look at, as part of this APBG. And we call it the APBG for longevity because one of the things that's come up a lot of in discussions to date is how we sort of see aging. And if we're going to get the general public really behind all this, we have to make it a lot more positive, and the whole way that we talk about aging and longevity, it has to be done through a much more positive lens. And I think a lot of the so-called market failures that we've seen to ignite the so-called healthy and longevity marketplace, that certainly the UK government are very keen on triggering, especially, with all of our strengths as a nation in terms of life sciences, the whole sort of financial services sector. And I see longevity very much a sort of cross-section of all sorts of different industries coming together. So I think that's where the disruptive potential is really seeing this through a much wider lens in terms of what we're really talking about, because we're seeing, social determinants of health. We're seeing that, health and wealth, it's all together in terms of, all the things that we need to think about in terms of having healthier, longer lives. And so we set about, when we held over the course of 9 months, about 15 advisory boards. We had 4 specialist advisory boards, one covering off science, technology and genomics. So that was chaired by Lord O'Shaughnessy. We had business, finance, investment and innovation. That was chaired by John Godfrey, who is the Corporate Affairs Director at Legal & General. So, knows the city. His former policy advisor, David Cameron, the previous government. And we had Lord Willits, who chaired the Public Attitudes, Public Policy and Behavioural Change Board, and actually David Halpern from Behavioural Economics Units ended up becoming extremely involved in the work that we were doing. And then we had Richard Barker chair the Population Health, Public Health and NHS and Social Care Board. And then we had a Strategic Advisory Board sort of process, so we would meet, sort of, drill down on some of the issues. We then pull out, look at a helicopter view, come up with some of the ideas that were coming through across the different groups. We then set a series of questions for a wider consultation exercise, because we didn't want to be seen as some elitist group, because we know, we wanted to involve, yes, the great and the good. We wanted to, and certainly my background is working very heavily with the tech ecosystem, and there's incredible ingenuity and ideas coming from the entrepreneurs, and certainly I wear a lot of different hats in AI and tech, work with NHSX on AI and data-driven tech, and there's so many amazing ideas happening, in all sorts of different industries. So we wanted their voices to be heard, and I think that's also another really important point, the voices that need to be heard. We talked about the invisible becoming visible, and so we tried to do that through the process that we went through over the course of 9 months, and this is all, with a tiny team, a lot of goodwill, and through this process, we got the involvement and support, and this became a true collaboration. I'll talk about sort of lessons learned, a true collaboration through a number of organizations who all came together around the singular goal that we had set, the 5 extra years of healthy life expectancy while minimizing health inequalities. And over the course of the 9 months, the health inequalities aspect became a much, much bigger focus. And of course, this is at a time going through the sort of, the Brexit, and of course we then had an election. We had to disband the APBG for a couple of months, reform, just 2 weeks. In fact, it was 3 weeks ago we reformed. And by then we had already developed our strategy and come up with our handful of what we felt were the key ideas, cross-cutting themes that were really going to deliver on this, the singular goal. And by the time that we ended up at the end of November with our strategy pretty much in draft form, looking at all the ideas, looking at all the evidence, through the wider consultation exercise, by then we had accumulated, and I can't even count the number of organizations who are behind us now, but certainly we have, key influential organizations like the King's Fund, Health Foundation, Genomics England, Institute of Health Equity. We have had incredible support, Duncan Selby at Public Health England, Chris Whitty, we've been having conversations conversations with CMO, the new CMO, an incredible process which shows just how we can galvanize and mobilize around a goal that makes a lot of sense and really has really motivated people to come around this. And I would say, so with the strategy, we're actually publishing, as we speak, we're putting together the final the layout for the report that's going to be launched on the 12th of February, so that's next week. We have already, we've got Matt Hancock, our Secretary of State for Health, who's going to be our keynote speaker. So through this process, we've had an incredible amount of support, and I would say that the lessons learned and some of the big ideas that I think we need to put on the table, and I will stop talking in a second, is we really need to, and I've been listening to a lot of the talks, and I know this is a fantastic initiative that we've got here, but I would say we really must mobilize business in a much bigger way in all this. I think they hold the key to part of the behavioral change and the mindset change that we really must, that is the biggest challenge, but the biggest opportunity to really drive this healthy longevity sort of mindset shift. It'll drive the business community, it'll drive a lot of the innovations that we need to see. And I think, I do a lot of work with the NHS and academic health science networks, and I see almost the biggest problem is that we have, as a public in the UK, we become almost addicted to the NHS. We need to wean ourselves off the NHS. We need to take responsibility, all of us as stakeholders in society, and we focus a lot in our recommendations in our report about, the contributors, we as citizens, and of course self-care, the role of business as a key stakeholder and a contributor to the nation's health. We're looking at a lot of the models. We've got the Prevention Green Paper that is out there at the moment, through for consultation, and of course they talk about a composite health index, looking to what New Zealand are doing in terms of the well-being approach that they take, where they look at the priorities of the government in terms of what are the real needs of society. So we're taking a lot of those ideas, and health and all policies is something that we're looking at as a key part of this, looking at prevention. Now at the moment, the NHS spends 5% on prevention. That obviously needs to be much, much bigger. So we have a plan around boosting that figure up to 15% spent on prevention over the next 10 years. Prevention is the key to all of this. And with that, there is huge excitement. And I would say one of the big areas that I know is dealt with in detail, I think in the third work stream in science and technology. But I think, there's a huge amount of opportunity and incredible investment going into aging research, the underlying basis of aging. We are really coming, it is absolutely mind-boggling and staggering how much is being discovered at the moment in terms of that, what is happening in terms of how we age. And I think, with that, I think a lot more focus, and of course, when we've got AI and all these data-driven technologies, really looking at the opportunity across the life course. We obsess over the NHS data set, which of course is 10 to 15% of the wider determinants of health. We've got this gigantic, what I call the non-sick data set, and the big tech companies, are already in this space, very heavily. They, all the data exhaust, all the data that shows what we're eating, what we're doing, energy usage, all these sorts of things, are massive opportunities to really see, develop products and services that will keep us healthy and well and drive this healthy longevity marketplace, and will help to drive some of the shift, that we do need to see coming from outside our institutions. And the key, it is about, the general public, driving a lot of the changes that we're seeing. So I can talk forever, so I'm going to stop there.
Thank you, Tina. So Robert.
Okay. Well, first of all, I want to express my gratitude for being here and being able to represent the PACE community at this event. So I'm going to answer your question by talking a little bit about PACE and how it works. PACE stands for Programs of All-Inclusive Care for the Elderly. And it's important to realize who actually can enroll in a PACE program. So to enroll in a PACE program, you have to be 55 years old or older, so not elderly at all. But you do have to be nursing home eligible as defined by the Medicaid program in the state that the PACE program's operating in. You also have to live in the defined geographic service area of the PACE organization, and you have to be able, the PACE has to determine that you're able to live safely in the community at the time of enrollment with the support of PACE services. So when someone enrolls in PACE, they already need a high level of care and services. Currently, there's over 51,000 people enrolled in PACE programs. There's 263 PACE centers. And of the 50 states in the District of Columbia and the U.S. territories, there's 31 states that have at least one PACE program in operation. So we're spread out pretty thinly across the country. If you're in a community where there is a PACE program, you might see the PACE van picking people up in the morning. You might see them running around town, taking them to appointments, or taking them home in the evening. You might be aware that there's a PACE center in the community and where that's at, and you might be aware that seniors go there, they do activities, they receive some of their health care needs. But from the outside, you probably wouldn't really understand PACE very well, because really the heart and soul of PACE is the work of the interdisciplinary team. And the interdisciplinary team in PACE is composed of a primary care doctor or a geriatrician, although they're becoming increasingly rare in the United States, a registered nurse, a dietitian, an occupational therapist, a physical therapist, a rec therapist, a social worker, a home care coordinator, a PACE center manager, a personal care attendant, and a transportation coordinator. And the key to what really makes PACE effective is that group of people working together as a team. And I want to use transportation just as an example of how the interdisciplinary team works, because it's kind of an unusual service to be provided in a long-term care setting. But a PACE medical director once told me that a person might tell their driver something that they would never tell their doctor. And then when you think about the driver as a familiar face that shows up each morning in the enrollee's home, a person that might be able to tell if there's something different in that person's home, if the person's usually ready at the door but for some reason isn't, or might have trouble ambulating to the van. Those are all things that might be data points that can go back to the interdisciplinary team. And the team can discuss that and may be able to come up with an intervention before a small problem turns into a big problem and another chronic condition. The other key to PACE that I really wanted to comment on is how PACE gets paid. There's a lot of complexity in how PACE gets paid because there's several revenue streams that go into PACE, and we could spend all day talking about each one of them and how they've changed over time and what we'd like to see in the future. But really the important thing about PACE is that all those revenue streams create a pool of money for the PACE program to use. Then the important thing is that once that money exists in the PACE pool of money, there's no restriction on how the PACE program is allowed to use that money. And because of that flexibility, PACE is able to do a lot of things. Most importantly, they're able to fill in a lot of the coverage gaps that would exist in a fee-for-service Medicare or Medicaid. They're able to work with family caregivers and provide education and support to family caregivers. However, with that flexibility, there is a little bit of a bargain for what that PACE has taken on with the Medicare and Medicaid program. PACE takes the place of everything that Medicare and Medicaid would pay, including if that person goes to an emergency room. You pay for the ambulance service, you pay for the emergency room care. If the person has a hospital stay, even a surgery, the PACE program pays for that. If a person has to go to a nursing home after a surgery for rehab, the PACE program pays for that. If the person is permanently placed in a nursing home, the PACE program continues to pay for that. That person continues to be enrolled in PACE, and PACE is involved in their care. So when a person enrolls in PACE, we plan on them being in PACE for the rest of their life. And at the most basic level, PACE is successful, or most successful, when it's able to substitute preventative and primary care for inpatient utilization. And as a result, and I think this is one of the things that's really kind of the part of the magic of PACE is that the incentives, the financial incentives of the organization align with the clinical incentives of the PACE participant and their desire to stay out of a nursing home or other inpatient setting. And the bottom line for PACE, our biggest sign of the success that the PACE program has had is that at any given time, 95% of our enrollees live in the community and outside the nursing home. Let's see. So just a couple of things to respond to the question, yes, and to wrap up. Some of the things that I think PACE really demonstrates is that payers can bundle payments and focus on key outcomes and allow providers to innovate around those outcomes. When interdisciplinary teams invest the time and effort to work together to address the needs of the population that they care for, you have greater results than you would have individually. And I could say more, but I think I'll wait for the discussion.
Thank you. Kasumi.
Thank you. I'm very much happy to be here and to explain the Japanese experience from the Ministry of Economy, Trade and Industry position. I'm from Ministry of Economy, not Ministry of Health. However, I'd like to emphasize the 5 points with regard from my experience. The importance of the think and act beyond the sectors from academic or the business or the governmental point of view. We have started to create the deep collaboration with the Ministry of Health and the Ministry of my ministries. That traditionally, healthy longevity or the healthcare things is then, of course, important Ministry of Health issues. However, in Japan, the super age societies, that in order to maximize macroeconomic situation in the future and encourage the new innovations, that we have to tackle with these issues. Otherwise, by tackling these issues, we can maximize the economic outcome or the micro innovation outcome. So therefore, my ministries or the economic ministries are very much interested in these issues. So now, under the Prime Minister Abe, we have great collaboration between across the ministries to tackle with the health longevity. This is one. A smarter country like Singapore or Finland or the Netherlands do the same kind of things. Second thing is then business and social security or the medical professions collaborations. In Japan or in many countries, the medical or the elderly care is not for profit. This is not lucrative business, not for money, but for heartwarming, smiling, the people's, the quality care is the important things. So therefore, if I exaggerate, medical professions have relatively good relationship with the volunteer peoples or the non-profit people, but they dislike venture capitals or the investors or the business people for profit. But actually, from business side, you can see the shareholder, the transition from the shareholder, the management to the stakeholder management, and also SDGs or the ESGs. Even the business, like let's say Unilever or the Johnson & Johnson, Japanese companies, they seek the contribution to the society, not for money only. So therefore, some collaboration between the business and the non-profit and the non-profit can be done. In Japan, as for the workplace, healthcare investment, we have started health and investment management things 7 years ago. This is then from the life course approach to the healthcare investment. The healthcare investment during the working age is, of course, important. But ordinarily, ordinary companies, CEOs dislikes the regulations or the additional cost. We say that why don't you invest to your employees' healthcare, health status? By doing that, you can improve creativity, you can improve productivity, and you can get good business outcome. This works very well. Now, in Japan, more than 2,300 large companies or 50,000 Japanese SMEs already employed health and productivity management. More than 10 or 12 million employees are covered by this voluntary program. Government provide any regulation. Government provide no regulation. Government provide no support to that. But however, as a business judgment, they are voluntarily investing employees' health. This is good thing. No one loses. And third is then, the Japan, how can I say that? Traditional medical professions like, conservative medical doctors in the rural areas dislikes AI or the digital things. Because then for them, the patient information is a very, the respectful, important things. They cannot share such kind of information to the, someone from IT industries. So how to create collaboration between the, conservative medical doctor and new IT, AI people from India. That our approach isn't just, Dr. Said yesterday, Dr. Kenji said yesterday that we envision the future, that you can do your healthcare providers, healthcare services, just as you do 10 years ago, 20 years ago, right now. However, think about 20 years later, that in Tokyo or the big cities, we have so many grandpa and grandma at that time. Maybe, so therefore, our hospital's bed or the elderly care home lacks capacity to provide services. On the other hand, in local areas like the Akita Prefecture, Akita State, or the Yamaguchi State local areas, the absolute number of elderlies will decrease. So therefore, the hospital or the elderly care home have to go bankrupt. So without using new technologies, you cannot provide basic healthcare to the Japanese elderlies. This kind of, the explanation works very well to the medical doctors or even conservative people. And also, as for the dementia, maybe 5 minutes past. As for the dementia, of course, the needs from dementia people is not one size fits all. So it differs person to person. But in order to, again, that we cannot rely on so many human resources to take care of one dementia people. The Japanese, my friend from Vietnam said 6 people support one elderlies. We cannot rely on such kind of things. So therefore, the new technologies, new services, or the new product to live with dementia easily, like dementia-friendly design, or the new, the AI coaching system to communicate with the dementia people. These kind of things should be developed based on basic typical needs of the dementia people. So therefore, we create private-public partnership to tackle with the dementia, to create new solutions to dementia. So finally, I would like to add the opportunity is very important. I respect Victor Zhao. He kindly provided good opportunity beyond the boundaries. We can gather all over the world, from all over the world, to discuss about healthy longevity. But in Japan, we have created healthcare innovation hub to connect various networks from the rural areas or from local areas, from city, various universities, academias, and businesses. Currently, 111 institutions or networks are integrated into one using the healthcare innovation network. We are trying to connect this network to the other network in all over the world, like Bangalore, Israel, Finland, Netherlands, UK, and the US, and Chile, of course. So that is the importance. That is what I would like to say. That how to encourage networking beyond the traditional sectors or beyond traditional academic areas. Thank you.
Thank you. Srina?
Good morning. I come from the background of non-communicable diseases embedded within the larger context of health systems and public health. I also represent the perspective of a country which is still demographically young and will continue to be so for next 3 to 4 decades. But with the large population that it already has a large number of people who are elderly. Therefore, I also bring the perspective of low and middle income countries where healthy longevity is still an aspirational goal and not necessarily an exasperational burden of weighed down health systems. So in that context, let me first deal with what we can do in terms of health services from point of view of learning lessons, and then from the arena of health policy. In health services, we have seen very clearly successes in the area of non-communicable diseases in some things that we take for granted now, whether it is vision aids, hearing aids, mobility aids. They've all come in because of an express population need, readiness of health services, and the ability of technological industry to respond with those devices. But we then move to more difficult areas of management in health services like blood pressure, diabetes control, all of which are important for healthy aging, reducing morbidity, and prolonging high quality of life in advancing years. But even there, we remained somewhat constrained by our organ-specific or health condition-specific approach. So the next challenge was, how do we actually address comorbidities from moving from organ-specific obsession to human-centric approaches in healthcare, as was even mentioned yesterday. That brought about not only a constellation of specialists, but more importantly, moved health systems towards primary care physicians, family physicians, and more importantly, in our own health systems, towards technology-enabled non-physician healthcare providers who could actually provide much of these services in an integrated, caring, compassionate manner at the front lines. I think that health system transformation has been an important lesson that has been actually pushed forth by the knowledge and is an effective example of transition in health systems. Now, of course, there are other examples that we could consider in non-communicable disease in the policy arena. For example, if you look at what the WHO proposed in 2011 as a part of the UN political declaration, and was later on reiterated in the SDG goals, you had non-communicable diseases goal set as premature mortality reduction between the ages of 30 and 70. Now, in this setting, that would definitely be considered ageist. So why should mortality between 70 and 80 not be considered premature? Why should that not be considered worthy of attention for attenuation or aversion? So those are important questions that do come in. But that mistake, I think, has been corrected partly by dedication to universal health coverage as the overarching health system goal in the Sustainable Development Goals. Because once we talk of universal health coverage, we are talking about equity across all ages. And the title of the goal itself, SDG 3, now says health and well-being at all ages. So, and universal health coverage becomes the platform for providing those kind of services. So I think that transition has been made even in the area of non-communicable diseases, especially in the area of service provision, even if the indicator of success of health systems is taken in a limited age group. But there are even more difficult areas where translation into policy of knowledge has become somewhat challenged, but still emerged successful. That is in the area of tobacco control. Again, something that I'm fairly familiar with. Now, people may say, what does tobacco control have to do with healthy longevity? But one of the largest increases in life expectancy and one of the major fractions of explanation for increase in life expectancy in UK or USA or elsewhere has been successful tobacco control. But that has been a huge political battle, not merely a health systems battle, and that has to be fought by integrating multiple streams of knowledge into effective multi-sectoral action. Therefore, you assemble the agents of change, then you actually advance science, you amplify advocacy, you accelerate action, and ultimately assert accountability. And that has happened too. So there have been many areas in the area of health policy as well as in health services when we looked at non-communicable diseases where knowledge has been effectively translated into action to enable populations to attain healthy longevity and enjoy a very productive and full and fulfilled life.
Thank you. So let me make a follow-up question for each one of you, and now I really want you to give a very short answer, then we'll open the floor for the rest of the people. So for Tina, I'd like to ask you, what are the key lessons on your view in stakeholder engagement? Do you think that there are models of innovative collaboration and partnership that have worked?
Yeah, I mean, I think throughout this whole process, I mean, throughout the whole process, I mean, some real fundamental sort of insights and obviously sort of examples of best practice have come about. I mean, one of the things, I mean, and I know that it's come up in some of the conversation just here, is just the sheer understanding of how we need to take a holistic approach to all this. You know, the things that we're discovering in aging research are just, you know, shedding real light on the clustering of diseases, you know, the chronic diseases, how we need to be much more holistic in terms of how we deal with those diseases. We know, and actually a lot of the answers already exist. I mean, we know unhealthy behaviors, the environments that lead to these unhealthy behaviors. These are the sorts of things that we know the solutions, and we just need to find a way to crack them. And I think the big sort of fundamental point, there's a huge appetite, you know, in the business community, and I think Kazumi had highlighted this, you know, of socially responsible business behavior. So, you know, there's a huge shift in sort of ethical investment. You know, we see that in climate change. We should be seeing the same thing in healthy longevity. And of course, the solutions for healthy longevity are actually linked very closely to climate change. In fact, that's one of the ways in which we're trying to inspire young people in this whole debate, because we do need to take a whole life approach to all this. We have to inspire young people to understand what it is that they need to do, even from an early age. And we have to start from pre-birth, of course, you know, across the life course, really to tackle some of to really deliver on healthy longevity. And I think, I mean, in the national strategy, what came about is you know, there are ways in which, you know, that government can have a role in terms of incentivizing social responsible business, incentivizing things like ageless housing, you know, social housing. You know, there are means in which we can incentivize and put investment in the right areas, these big infrastructure projects that are critical really to deliver on the goal. The other really important point, lessons learned, is the huge importance of community and place-based approaches. And again, this is where social enterprise and business and working with NHS and local councils, etc., you know, could really invigorate local communities. I mean, we see with the new Conservative government, I mean, obviously they have a real job to do to level up, as they say, you know, the nation and focusing on those areas that have been left behind. And so, of course, our national strategy, especially around this very important goal of minimizing health inequalities, which, of course, you know, we've seen has actually the gap has been growing between the richest and poorest citizens. So that has been a real focus in terms of our action plan. And of course, the community is, you know, holds the key to all that. And one of the examples I'll mention on that point is there are many examples actually of incredible stuff that is happening at a community level, which no one ever hears about. And you hear some of the examples, like in Wigan, for example, the Wigan deal it's called, where at a time of austerity, through their local leadership and through actually trusting their citizens and giving even a little bit of seed money to actually, you know, take charge themselves of what they need to do as a community, has actually led to a closing of the health inequality gap in their area. So it is possible with even little bits of, you know, trusting, you know, seeing your citizens and your communities as assets, investing in them. You know, these are the sorts of things that can really revitalize communities and regenerate things like the high street, which, you know, are ghost towns in many places. I mean, can you imagine what we could do if we, used all these spaces that have been vacated by the banks and all the rest of it, using those places, for exercise, for social gatherings, for all the, and revitalize those areas where people used to go and where people don't go anymore, but actually were the reasons why people got out of their houses and walked to the center. I mean, these are the sorts of things that we need to be seeing much more of and are great opportunities. So I think collaboration around delivering on socially responsible shifts in practice, need to be the focus and are very much at the heart of our strategy.
Thank you. Robert, I'd like to ask you the following question. How do you think we can plan not only for the generations that are elderly today, but how can we put a focus on sort of a life course approach and work with the people that are currently youth or young adults and introduce in them this notion of healthy longevity, when healthy longevity for them is most of the time an invisible issue?
Yeah, and I think one of the things I think would be key to that is to be able to make seniors more visible in the communities that they live in, so that you actually can see examples of successful aging in communities, so that people will have something to strive for. And I also think that there's a lot of possibilities in being able to form intergenerational programs where younger people can work with elders, and the elders can give back to the community in those ways. And we've seen that with the PACE organizations, with the day centers, being able to either go out into the community or to bring the community into the PACE center and work with the seniors. And it's been very positive.
Kasumi, talking about that, because you're basically saying, Robert, that we need to make visible the invisibles. But then there is another aspect on there. How do we make this issue visible in terms of governments, and how do we build sort of the political and business case to invest in healthy longevity, in particular in countries where there are still young countries don't see this issue?
The simple answer is then to make these issues as now whole of the government or the whole of the economic issues, just not as part of the government or the part of the society issues. By how to do that? We have several approach. The one is as I pointed out in Japan, that we have highest level economic committee under the cabinet office to discuss macroeconomic policy and innovation policy. The healthy longevity is then one of the top issues in that areas. And in the discussion, our explanation, our advocacy is this way. Let's say who decide that the elderly age is 65 and more. The Japanese gerontologist says that based on the current trend, or based on encouraged prevention and encouraged medical or the elderly care, we can change the definition to the 75 years old. Well, that's good things. However, from macroeconomic policy point of view, if the supported the threshold is changed from 65 to the 75, the Japanese future fiscal policy or the Japanese macroeconomic situation will totally change in the sense of the consumption, in the sense of the production. So therefore, the economic side is very appetite to achieve that. So such kind of discussion is going on. And so therefore, the healthy longevity is the main topic of the Japanese Nikkei newspaper. This is one. And second is from private side, we formed the Japan Healthy Committee, Nippon Kenkou Kaigi, Japan Healthy Committee. This is the private-led initiatives. The two top CEOs, the one is now top of the Japanese Chamber of Commerce, Mr. Mimura. Very big, the Japanese Chamber of Commerce have more than the 1.5 million Japanese, the businesses members. And another CEO is named Dr. Yokokura. He is the head of the Japan Medical Association, the former head of the World Medical Association. These two, private sectors lead the health investment prevention, the national activities, not by government, but by the private. So, and also we can create various, how can I say, to new advocacy to the societies or to individuals. The ageism is, our not enemy. Ageism we have to tackle with that. But in Japan, we are saying, the government or the private company are saying the 100 years old life or the, our demography is changing to the 21st century, from 19th century model. 19th century model, where the elderly was very rare, only a few percent of the demography. But in 21st century, from Japan, the 2050 and later, the elderly rate will up to roughly 40%. So the elderly is actually the main component of the societies. So ages will be naturally decrease. So by saying such kind of message to the peoples, that we would like to change the atmosphere. Maybe I stop here.
Thank you. A follow-up question on that, Srina. This is an area where there is a lot of knowledge on things, on how to do things. However, the key issue is how do you build the political will when governments have several competing priorities? So I'd like to ask you about your views on this subject of building political will to act.
Well, if we want to look at political will as emerging from enlightened policy making or leading to enlightened policy making, I don't think we can be quite content only with pushing the scientific argument of the scientific evidence. An enlightened policy requires scientific credibility, financial feasibility, operational steerability, and political viability, which means it requires a confluence of evidence from biomedical, epidemiological, and clinical research for scientific credibility, health economics and development economics research for financial feasibility, implementation and health systems research for operational steerability, and social science research for political viability to see what the contesting elements are, who are the potential supporters, who are the potential opponents, rival claimants, and so on. Unless we bring a confluence of all these streams of knowledge, we will not be able to influence policy in the right direction. Therefore, the first need is truly well-assembled, multidisciplinary research which can feed all these streams of knowledge into policy. The second is, of course, messaging. How do we actually change the messaging? I think the dismal talk from economists of what has been called the dependency ratio has always been a bit of a negative influence in people's thinking. I think we must move the talk from dependency ratio to basically looking at this as a necessary and appreciated attainment of human development as it advances. I think healthy life expectancy is to be celebrated as a shining symbol of civilizational success in human development, a milestone rather than a millstone. And if we can actually project that and show that as an aspirational element, then we will be changing the conversation. Thirdly, I believe it is important for us to build that intergenerational compact, not of multiple generations competing with each other for limited societal resources, but complementing each other in collectively utilizing those resources for mutual good. And building that mutual compact is going to be very important because, firstly, the elderly are going to be an important resource for intergenerational transfer of intellectual and social capital. And the young are going to be important support systems for the elderly as they advance into later years of life for a variety of emotional as well as physical and social support. So I think this question of intergenerational compact is going to be critical, but that again is going to be possible only when we can actually bring in the conversation to mutual benefit and mutual support rather than competing demands. So I think the political will actually is going to be generated if we create those kind of pools of scientific evidence, change the conversation and the framing of the issue, and build in coalitions among the different generations. And I think that is the way political will advance into policy and action.
Thank you. I'd like to open the floor for question. I see that there are several. So let me begin with, yes, please. And then yours.
I just want to carry on this theme of the knowledge base and the research gaps and the science of translating knowledge into practice, which Professor Rayleigh talked about. And one additional element, because what we're talking about, the knowledge base, because these are complex interventions. So the people already recognize that even in political services, many interventions are not one intervention. There are multiple interventions. And particularly for these issues in society, they are complex interventions, and the knowledge base is very poor. So when you look at systematic reviews of anything of these things, usually the quality is poor, because they have not, the methodologies have not been really developed. The science is still embryonic. There are a lot of assumptions. So obviously doing a meta-analysis of these things is just nonsense in my view, because the basic elements of it are not there. But one needs to have a starting point of starting with identifying what the interventions are and the basis for it. And then the other part that Professor Rayleigh talked about are the decision-making process in government. To understand that, the processes, the decision-making process are something that we in public health, many of us don't understand, or in health systems. There are many decisions that are made when it comes to the policymaker's agenda, who gives the advice, on what basis is the agenda, on the intervention, how good is the evidence. So those are the other elements of the knowledge base. And the third knowledge base, which is problematic, is now what you referred to are the implementation sciences. So when you are implementing things in society, it's a very complex organization. They talk human behaviors. We talk about organization behavior. And we have not talked about these in this session because there's a whole element, the whole science in terms of looking at the fidelity, adaptability. When you implement all these things in big like even the PACE programs, each program I'm sure is going to be slightly different from the other because the context is different. So many of these interventions when you look at in the future, even though we have good models, but how are these actually translated into real life? What are the fidelity, what are the components that are key and cannot be adapted? What are the components that can be adapted or should be adapted? What are the barriers for the adaptation in each context? So those are issues if we really want to talk about the whole system in the future, getting this wonderful model that we have and then translate it into practice, in policy and then into practice. There's a very big divide. And there's a lot of science that needs to go in. They're not the basic sciences that we understand as doctors and health professionals and public health people. But we need to put more emphasis in some of these policy sciences and the sciences of complexity and implementation sciences, which is something that I hope that the panel can consider.
I fully agree with that comment, sir. I believe multi-component interventions in dealing with complex systems require different types of research design and assimilation of knowledge from different sources. Unfortunately, our approach of classical RCTs becomes a bit too reductionist in this area. We need to keep reminding ourselves that the spectrum of science is reductionist in content, but holistic in context. And there can't be a better context to illustrate that than healthy longevity.
I might just, from a provider perspective, the whole idea of how do you take this knowledge and actually operationalize it can be very frustrating. For PACE organizations who are serving communities and have a demonstrated track record of successfully caring for some of the most frail people in the community, one of the things that we've been trying to do for several years is to develop pilots where we could take care of people that are don't quite meet that nursing home level of care, but need care to stay in the community, need care so they don't become nursing home eligible. They don't deteriorate over time, but there's not a payment stream for that. There's not a way to provide that service, even though that service is not being provided in the community. So there you have knowledge, trying to implement it. You actually have the resources, the people in place that could implement it, but there's not the policy desire to implement it.
Just a point, just from my experience, having worked with a number of organizations and institutions. Again, going back to the point that, given the furious pace of change happening in technology and science at the moment, and also the general public. I mean, we have to remember, the baby boomers, Generation X, they have very, very different expectations, compared to previous generations. And we're already seeing, if you look at what people already, the trends towards veganism, low alcohol drinks, there's the consumer already wanting more of this, and so we have to really sort of make sure that we're catching up to consumer trends as well. And I think one point that I know Matthew Taylor at the RSA made, which I think is a very good one, is that in this new world, organizations, institutions, they're just not fast enough to change at the moment, especially with technology as it is at the moment, especially with the general public. And so institutions really have to think of themselves as system thinkers, but acting like entrepreneurs, far more agile, far more able to look outside of their walls, their silos, looking ahead, looking at actually what's happening in their environment, which is changing very, very quickly.
I agree with the importance of the evidence level, especially for example, we have struggled with then to create the new evidence for the dementia prevention or the dementia speed control. Of course, we are doing an RCT based on the finger study or the single study for the multi-intervention to the MCI peoples. Of course, then such kind of evidence is important. However, in order to evaluate various actual solutions for dementia prevention, the only RCT cannot work. We need additional, more, how can I say, the loose level evidence, but some kind of the standard to evaluate actual services or the products. So I agree with the pointed out, and we have struggling with that.
Thank you. Please.
Thank you very much. Very inspiring. Ryoji Noritake from Health and Global Policy Institute. It's a Tokyo-based think tank. My question is about the political situation of this disruptive 21st century that we observed the Brexit, Tea Party movement, libertarian movement, which is sort of like insular nationalism, and their claim that Big Brother is now controlling not only what we should eat, drink, but how long we should live, how long we should be healthier. And those people who are in this room, we have a good education, good adherence to the treatment, but those who dropped out from the treatments or don't care about the health promotion are basically the similar population. What kind of a discourse, narrative we should develop to convince those people who actually needs support? Thank you.
Very, very interesting question. Who wants to take?
Well, I can try and tackle it. Well, it is easy to be a bit despairing and despondent about the global situation at this moment. But it's also good to remember, if I may speak frankly, that the young people in the United States voted against Mr. Trump, that the young people in UK voted against Brexit. There are young people now standing up in international fora pleading for environmental protection, whose voice is now reverberating around the world. So there is plenty of hope as well. I think we need to mobilize all those forces and essentially ensure that those who have a vision for future of humanity, which is consistent with equitable human development, and respect for human dignity, that those will prevail. It is not going to be an easy battle, particularly, as you said, with the kind of social media and the kind of fake news that pervades. But that battle still needs to be fought. And I think it is possible to unify people around certain common causes, provided their value is apparent for intergenerational sustainability. And some of the aberrations that are there now can be contested. I do not know what's going to happen in the primary today in the United States, but I'm hoping that some changes will happen across the world where some of these trends can be combated. The fact that you're raising concern about this itself is evidence of the fact that there is now a resistance to some of the negative trends.
If I could just comment on so what I'm hearing in a lot of the discussions that I'm having at the moment from all sides, from business, public sector, etc., there's a calling for a new social contract with society. All stakeholders in society, and I think there is starting to happen this sort of consciousness. And if you speak to the Accentures and the KPMGs, that is all very, very top level discussion with all their clients. Socially responsible behaviour. It's very much enshrined in a lot of the ideas in the national strategy, as even things like developing an index for how business can contribute to the nation's health. Health is our greatest asset. Health in all policies. How do we help left behind communities? And I think there's an interesting shift, and even in this sort of tech AI sort of big tech sort of space, we're seeing lots of there are a lot of fears. For example, what's happening in China, marching ahead in artificial intelligence, social credit policy. We've got big tech. Sort of fears, in the US. We've got an interesting sort of situation, obviously in the EU, where we've got, these sort of the common digital market, ethical approaches to data. And I think, going into the local scenario in the UK, for example, again, I think there's this whole shift moving towards local, where you can trust local communities to do what they feel needs to be done for their local populations, trusting citizens. I think I'm a great believer in trusting citizens, and I think even in this new world of AI and technology, I'm speaking to some really fascinating data scientists, professors who are all experimenting with civic sharing models, civic data cooperatives, people like Ian Buchan up in Liverpool, harnessing data in their local communities, very deprived areas where they can leverage data, encourage civic data sharing, where they can then sell on that data and make sure that the value of that data goes back into helping their local communities. It's all these sorts of ideas, really helping local communities. I think there's this whole kind of global to local kind of tension at the moment, and I think that's what we're seeing playing out in a lot of what we're seeing today.
Thank you.
So in the United States, most of the long-term care is paid for by the Medicaid program, which is a federal-state partnership program. But it does, that comment really does remind me that the Medicaid program has been a stigmatized program for many years, many years. My grandmother, when I think I was describing PACE to her many years ago, more than 10 years ago, and she said, I would never even apply to be on Medicaid, even though it was something that she's paid for through her tax dollars for a long time. I think, so we also have seen with the Affordable Care Act, we've seen many states just leave money on the table and not take it and make it into a political issue. So I think one of the things that probably would be helpful going forward is to really rebrand Medicaid, to really change the name of it, to brand it more as a state-specific program and have states actually take pride in that program and really be able to make it into something that supports their local communities. And I know that's, there is a state that's done this, but I can't remember what it is, but it would be a good case study to look at.
Of course, no one-size-fits-all explanation to everyone. The different people is convinced by the different, the explanation. However, the one type of the explanation, like an inconvenient truth type, the explanation may works to someone. Maybe that for ordinary people in the world, the healthy longevity or as I said, 100 years life, the high life expectancy is now only for limited countries. some OECD countries or some Singapore, the limited countries, they may think so. However, in 21st century, almost all countries will become super aged societies. And life expectancy is, fortunately, will expand to the 80 years, 90 years, 100 years old. So assuming such fact, people should be responsible for the future generation. To take care of one's health is just as taking care of the earth. That we have to be, in order to continue sustainable lifestyle, sustainable, the societies, we have to take care of the one's health. Such kind of, explanation was made, 40 years or 30 years ago in the sense of the environment things in 20th century. So we need some big explanation for the 21st century.
Yes, please, and then yourself. I'm sorry. Yes,
Hi.
please, go ahead.
Hi, Adrienne Mendenhall with Access Health International. So combining both the comments around trust and then also the comments that we had around technology and how institutions need to become more entrepreneurial as well. In Singapore, there have been a number of startups that are focused on home care that have been quite successful that launched a few years ago, and they're even starting to expand into the region. One of their big challenges is how to work with large institutions. So how could the institutions, I admit some cynicism in getting large institutions to become more entrepreneurial, but instead, similar to corporations, how can institutions become more adept and flexible in ways of working with startups and the entrepreneurs and those who are able to innovate? And can you give specific examples of where you've seen institutions be able to do this in a way that helps these models that are happening on the ground, where there is this trust, be able to scale up as well?
Okay, just hold your response because I want to take a couple of questions first.
I wanted to talk about the private-public partnerships in terms of a strategic way forward. First of all, I must be honest and declare interest. I am addicted to the NHS. As a symbol and product of solidarity. I'm not addicted to outmoded ways that it sometimes functions or delivers. So perhaps I'm halfway towards agreeing with Tina on that one. My question about public partnership is this. We've seen lots of opportunities. There has been examples, and we've been encouraged to look at the possibilities that those partnerships have for rapid scaling up of innovations to provide sort of solutions for specific problems. And I think the evidence that is growing quite well, and there's lots of examples of it. What I want to raise is slightly different public-private partnerships, and that's the strategic alliance. And what I wanted to really get some feedback from the panel was, how do we as a movement, as a social movement, addressing these issues of the human milestone in a spirit of solidarity, how do we guard against the agenda being hijacked at a strategic level as a market opportunity rather than as a partnership to deliver solutions? Perhaps I could ask Tina.
Okay, so I'll come back to you immediately. Tina, please.
So, I mean, I can answer both questions to a certain extent. So, that have just been raised. I think, in the end, what I think is a recipe is that has to be mission focused, and I think there has to be a way of setting what the partnership is trying to achieve and what the metrics of success are, and there has to be a contract between all stakeholders in that collaboration to sign up, to that shared vision of what we're trying to achieve together. And I think you can avoid a lot of headaches by going through that process. And I find, because I think there's a win-win for business, for third sector, for everyone working together in a mission-driven sort of arrangement. So I think that's a new way forward. It's something that I've been doing quite a lot of, wearing my other hats, working with health insurers, for example, with the tech ecosystem. And just going to the earlier point about how to make it work and trust. I think, and I say this running two social enterprises myself, I think the challenge is a question of speed, agility, and decision making. Because a startup or a small organization, they are, speed is everything, agility is everything, and of course larger organizations, large institutions. I mean, they are working at a pace that is completely alien to a small social enterprise or a startup company, which are often obviously cash flow, all those sorts of things, which are, and by the time that we've done the work, by the time an organization has even had their first committee meeting for a decision. I mean, it's so I think aligning the pace with which we work is one of the biggest difficulties actually with startups, small organizations working with big institutions. So that needs to be squared. But yeah, I think mission driven is the way forward, and I think within a new sort of social contract that I think is something that is starting to really resonate, and I think big business is actually signing up to in a big way. I mean, I can't tell you how many conversations I'm having with the big management consulting firms. That all the big banks are talking about it. It's they realize that there is something needs to change, that they have to do things in a different way, and that it kind of comes back to the B Corp model in the States, which hasn't really taken off in a big way in the UK yet. But it's like seeing the stakeholder. It's not only shareholder returns. It's a much wider concept of the stakeholder, and I think that's where we need to move, and that's certainly very much the spirit in which all the work that we're doing in the APPG and in all my social enterprises, actually, it's in that new way of thinking and doing. And that's hard, but I think it's the way forward in the future, personally.
Thank you. Srina, you wanted to say something?
I think it's time now to redefine the term PPP. Rather than defining it as public-private partnership, which sort of limits it to a governmental public sector entity and a private sector entity, it should be seen as a partnership for public purpose. The public purpose should be defined, the deliverables will be clearly defined, and the accountability mechanism should be clearly defined. Then it can be a government to private sector partnership. It can be a partnership for a public purpose between two private sector entities, between private sector and an NGO, or two NGOs. You can have a family of PPPs, but all serving a well-defined and generally agreed public purpose. And then we can move the conversation to the level that you wished.
Yeah. Katsumi, very short because we need to.
As for the PPPs, the ordinary PPP says a private-public partnership, but I would like to emphasize that collaboration between the non-profit people, including the government, and the profit people, including a business. So these two collaboration is a very key. And also, I would like to emphasize not only the national government, but also local government, governor or the mayor plays very big role. My friend from Kanagawa is sitting there, and Kanagawa is very appetite to nurture the new innovation or to create new solutions. So we have to connect the businesses with Kanagawa, academic with some mayors or the local cities. Thank you.
And just real briefly, there have been several PACE organizations that have been started by local industries or foundations, so they really wanted to bring something new and innovative into the community.
Thank you. So you have the last word.
Thank you very much, John Wong from Singapore. I think it's a fantastic panel. I'm wondering whether to actually translate this into policy and practice, whether societies can identify a sandbox to actually test this at scale. I mean, I see this happening in Japan. I liken this to what China did 30 years ago when they identified Shenzhen and a few cities to transform China. So we try and identify a geographic area where we bring in all the elements that Professor Reddy mentioned. You bring in academia to bring in the science, you bring in the entrepreneurs to bring in the time-driven entrepreneurial spirit, and then you need to bring in local government. And I think that combination, which is mission-driven, but at a sandbox so that they can develop the constant learning feedback cycles, because I think that's critical. With the metrics that we discussed in the first session, we define the metrics, we get the different stakeholders, and then we do this at scale, but in a sandbox so that no one feels threatened, and then take it from there.
Yes.
Completely agree.
Any comments about that?
I completely agree with that whole approach. I think it needs to be agile, it needs to be iterative, it needs to be learning, it needs to be all together. I think a lot in the UK, especially around the Aging Society Grand Challenge, we talk a lot about place-based approaches to this, you know, sort of, and I think that's where some real magic could happen. I personally have, you know, some beliefs around how we can really develop sort of data-driven ecosystems along those lines, you know, thinking about having a much broader view of the data universe, looking at some of the successes, for example, that's been happening in the banking sphere and open banking, opening up the ecosystem, the whole stimulating fintech, which has happened in the finance space. We can move that sort of collaboration, that kind of way of working into what I call an open life type concept, where you're, you know, leveraging insights from across the data sets, you know, across our lives, where you can really start to look at all the opportunities, you know, in aging research, biomarkers, you know, looking at, you know, potentially the cures for dementia. This is all within our grasp, you know, multimodal AI, all these sorts of things. So yeah, I think that the opportunities are enormous.
Yeah. Well, let me ask you one last question to all of you. If you were to choose one single disruptive action to increase knowledge or, in fact, the way forward, what would that be?
Well, I'll go first then. I think there's a lot of potential around building a movement that supports family caregivers, and not only family caregivers that are in the moment today, but people who are looking in the future and know that in the future they're going to be family caregivers and they're going to be cared for by family caregivers. I just think there's a lot of potential there to really make this very individual and personal for everybody.
My turn? Okay, one thing is then, as I mentioned, you know, SDGs, Social Development Goals. Please read the SDGs. Currently, of course, they have the third one is the healthcare. However, the main issues written there is 20th century issues. So no 21st century issues, including the healthy longevity. So therefore, I would like to create new SDGs goal for healthy longevity.
I would push for an expanded cadre of technology-enabled community health workers, not only to deliver essential services at the front lines, but also to provide the health and nutrition literacy and community mobilization required to build coalitions for advancing healthy longevity at multiple levels, from practice at the field level to articulation of public opinion for policy change at the policy level.
Thank you. Tina?
I'll just pick up a little bit from the point that I mentioned earlier about open life. I mean, I think it would be, I think one really interesting idea, again, going back to sort of the public purpose and the public good, et cetera, is, you know, data being the world's, you know, most important asset, apart from our older populations, of course. You know, data, being able to harness it for the public good. We have, you know, competing sort of data models. You know, we've got big tech, we've got China. We've got an opportunity here to really look at data as a way in which we can harness feedback into the public good for, you know, for everything from ethical research and aging, you know, and all sorts of big projects that will deliver on our healthy longevity goals.
Thank you. Anyone that would like to share a disruptive idea? Yes.
Nir Barzilai from Einstein and NUS, a great panel. I was just surprised, you know, if you start at the patient has a doctor, a nurse, a caregiver, a social worker, and some of them are not paid from the same pocket, and it's not clear really who's the boss. I think this is part of what has to be considered. Who's the case manager, and who's paying for the whole management, and how does it affect policy? So for caregiver, like in the UK, I'm thinking, if most of them come from Eastern Europe, now the Secretary of State will have to be involved in order to give permissions for those people to come, right? You're going to have many pockets that actually have to trickle down, and I don't think this organization, as far as policy and practice, is well established. How do you do that?
Thank you very much. Well, let me ask you for a big applause for our panel. And thank you all for your participation. Thank you. Now we are going to have lunch.